Focal and segmental sclerosis is a pattern of glomerular injury that we see by light microscopy. When some glomeruli are globally sclerosed, like for example here, or others are segmentally sclerosed, like for example here. So, as you can imagine, a number of different conditions and diseases can lead to this pattern of injury. To first clarify the terminology, processes that are involved in less than 50% of glomeruli we will call focal, and those that involve more than 50% of glomeruli we will call diffuse. Also, when we look at individual glomerular tufts, if the process is involving more than 50% of the tuft, we will say it's global involvement, and if it's less than 50% of the tuft involved, then we will say that the involvement is segmental. So these divisions are somewhat subjective and arbitrary, but you get the general idea. So causes of focal sclerosis are many. I will start with primary FSGS, primary focal and segmental sclerosis, which is a diffuse podocytopathy that presents with nephrotic syndrome. It's idiopathic. We know that in at least some patients with primary FSGS, the disease is mediated by circulating factors, and we know that because when we transplant these people, they recur with nephrotic syndrome in a transplanted kidney. But that's just a subset of patients. In others, we don't even know what the possible mechanism is. Some patients have familial focal sclerosis or genetic, so the genes for different proteins that constitute the podocytes or filtration membrane, they can be involved, and some of them include podocin or alpha-actinin 4 and so on. So a number of them have been described in the literature. Then focal sclerosis can be secondary to a number of different glomerular processes. For example, here you see a crescent with segmental fibrinoid necrosis. As you can imagine, this will actually really heal and form segmental sclerosis, as you can see to the right. So this is secondary focal sclerosis due to glomerular scarring. And we have to think of different etiologies that are along those lines. So crescentic and in general inflammatory conditions would be in the background. But then we also have secondary focal sclerosis due to adaptive changes, functional and structural adaptations. And I really want to spend a few minutes on this category because I find it most confusing for people, and I think this category really deserves more explanation. First of all, there are a number of ways that you can lose kidney mass or nephronal mass. You can even be born without one kidney or without one functioning kidney. So either you will have unilateral renal agenesis, or you will have segmental hypoplasia or dysplasia on one side, and then you would have another functioning kidney. You can have a number of different primary glomerular, tubulointerstitial, vascular processes, cystic diseases, and so on that can really reduce the number of functioning nephrons. You can also see that in some people, they will undergo nephrectomy procedures, either partial or radical nephrectomies, and they can lose nephronal mass that way. I mentioned vascular process. You can have massive infarcts of the kidney parenchyma, and that can reduce your nephronal mass. Glomerular processes can knock out your nephronal mass, as mentioned, whether they're crescentic or inflammatory, and they result in scarring. So, for example, some patients that develop post-infectious GN in childhood can actually have some really aggressive forms that can knock out a huge number of nephrons. And then they recover from that initial injury, and they can develop chronic renal failure when they're in their 40s or 50s or 60s. And I really wanted to talk about that problem. So the surviving nephrons, as you can see here, um, uh, are much fewer now, and they will have to take over the entire function. So what was supposed to be done by 100% of glomeruli now has to be done by 50% of glomeruli. So to compensate for that loss, the glomeruli will first enlarge, and then they will really work very hard, and they were hyperfilters. So what was supposed to be filtered through 100 glomeruli now has to be filtered through 50 glomeruli. Um, so to do that, they will also develop intracapillary hypertension. So you will actually push harder through surviving nephrons, so you can actually filter more and compensate for the nephronal loss elsewhere. So these surviving nephrons will really work very hard, and some of them will get injured in that process. So first of all, first adaptation would be actually enlargement or glomerular hypertrophy. You see here several normal glomeruli to the left, and then you have this huge, giant glomerulus to the right. It's probably 2 to 3 times bigger than normal. So now imagine how podocytes feel in this situation. They're postmitotic cells. They don't normally replicate, so they will have to now stretch themselves over this increased surface. So they will have to adapt to this change as well. And then you have those functional adaptations, as I mentioned, with increased intracapillary pressure and hyperfiltration and so on. So these patients will first develop a gram of proteinuria or less than a gram, then a full gram, then 2 grams, then more than 2 grams of proteinuria. And they can actually have substantial proteinuria with 5 or more grams of proteinuria. Overall, a lot of hard work for a surviving nephron, and some of the nephrons will not be able to take these tasks, so they will slowly start to get injured and die themselves. And this will further burden the remaining surviving nephrons, and the injury will progress. And that progression is not linear many times, but it really looks more like this. So as you actually leave, or you're left with fewer nephrons that are capable of filtering, you will actually eventually run out of kidney or all available nephrons. When you look at the electron microscopy in these cases, you will see that podocytes usually look normal. So this is not a primary podocyte disease like primary focal sclerosis. These patients have a different mechanism for their proteinuria, although it can be very prominent proteinuria. It really doesn't come from primary podocyte disease, but from that hyperfiltration. So the mechanisms of proteinuria are very different, and the mechanism of progression is very different. And the way these people will behave in the transplant, how they will recur with their diseases and so on, it's going to be very different. So the management and the prognosis is very different in people with secondary focal sclerosis. Sometimes you may have on electron microscopy focal effacement of foot processes, but you will see usually large areas with normally preserved foot processes, and that's going to be a giveaway, and that's going to tell you that this is really a secondary form rather than a primary form of focal sclerosis. I hope this clarified some of the concepts behind primary and secondary focal sclerosis and how you actually develop structural and functional adaptations. Thank you for watching this video.